Hello, and thank you for joining us for today's hybrid education program at Cancer Support Community. I'm Rebecca, the program manager, and I welcome you to this workshop titled Advance Directive and POLST Form. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Excuse me. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join a community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free, for those online, please feel free to enter your questions into the chat function found at the bottom of the Zoom window, or you can unmute yourself and that'll let me know that you have a question you would like to ask Karen verbally. Without further ado, I introduce our workshop speaker. Karen Morin is an oncology and a hospice registered nurse with more than 3 decades of clinical experience and is the founder of LA Patient Advocates, a patient advocacy and end-of-life consultant firm. She is on the medical advisory board of Compassion and Choices and a volunteer with the Action Network. Thank you so much, Karen, for being here with us today. Oh, Karen, you're on mute.
Adjusting our technical situations, I want to be able to walk around and work with everybody who's here in the room and speak with those of you online. So definitely answer any questions you have. The forms that we're talking about today are the advance directives that we fill out in order to tell people what we want in terms of healthcare. No, it's not. There we go. Okay, now let's see. Yep, okay, we got it. All right, we're in business. Technology is on our side. Okay, great. So I come a couple times and talk about the whole issue of end-of-life options and, what are our choices and how do we make them known? And one of the things we tend to skip over in each of these presentations is the actual paperwork and what's involved and what they ask on the paperwork. A lot of people say, oh, I filled out those, oh, we did a trust. And I always think the worst place you want to be filling and signing these forms out is a lawyer's office, because then you're not getting your medical situation involved in this paperwork. So what we brought down and what we have today are we have the advance directives. First, okay, we all talk about how we want to die, where we want to raise my hand and say, all right, I want to be in the hospital and I want to be manageable. But we all have different ideas. Conversations that come up with family, it happens, oh, you heard about a neighbor or there's a cousin who recently died, and those circumstances come up and starts the conversation about what we want and how we want. And that's important because we want to talk about death and dying frequently. We want your family members to hear you talk about what your wishes are a lot, often, and under different circumstances. So we're going to talk about those circumstances now, what you want and what you don't want, and how you can best get that message across. The harbor news, you're going to tell your doctors what you want. The only time these documents come into play is not able to speak for yourself. So That's important to know, because up until that, you're going to be telling them what you want and what you don't want. You know, most people say, oh, I know what I want, but they really haven't talked to family about it. I know, I do this all the time. And I'll bring about death and dying, and my kids will put their hand up going, oh, not now, Mom, not now. So sometimes we have to say, no, now is the time to talk about it, because this is really important to me and you need to hear it. And when I say we need to do it frequently, our health situations change from time to time. And that's why it's to bring these up, look at your documents, and redo them from time to time. I know I'm getting to that slide. It's on the slide. Oh, you can see I've been working on these slides. And so the Advance Directive is actually a legal document, and it's going to be signed and witnessed. So everyone should have one. Doesn't matter about your mental, your physical, or your age. Well, you have to be 18 or over, but everybody should have an Advance Directive that talks about really what their values and when it comes to healthcare. It's going to make your end of life wishes known, and it's going to avoid conflict and confusion later on among your loved ones. Oh, yeah, I heard her talk about it, but oh, it's really written down here. We want to treat Advance Directives as an ongoing process. It's not one and done. Like I say, our feelings and our ideas and how we think about healthcare is going to change as we go through different illnesses. So revisit them yearly, or if your health condition changes, and make sure that you're able to provide guidelines to your family. Why don't we do this? Why don't we pass out the Advance Directives? And I brought two different forms or types with me today. Different hospitals might say they have, but these are both California Advance Directives, and one is a little more descriptive. It's written at a much younger age group. And another is a little more, how will we say this? It's more legalistic. Oh, you know what? Hand me one of the legal ones. I think I gave you one of mine. Hang on. All right. So the first thing you have to do is you have to be this advocate, healthcare advocate, who's going to be your agent if you're not able to speak for yourself. So who are you going to choose? I've had people choose their neighbors. You could choose a spouse or family member. If you don't have an Advance Directive, the law is going to go in order of spouse, children, other relatives, siblings. You know, there's an order that they'll go through. But you can name whoever you want to be your decision maker. And so a lot of the paperwork really has to do with putting that information down about that decision maker. You want someone who is close to you. It used to be we wanted someone who lived near you, but you know, it's 2025. We have the internet, we have phone calls, we have FaceTime. So if it is someone across the country, that's fine, because the hospital is going to be able to get in touch, explain the situation. And so you want someone that knows you, someone who's calm. Maybe sometimes people pick someone who knows a lot about the medical system, and someone who communicates well. And like I say, someone who's really knows your values and what's important to you, and you know is going to stick up for you. Yeah, sure.
Just a moment. Go back to the previous screen. I didn't get a photo.
Oh, you didn't get a photo? Okay. Yeah, it's all being recorded too. It'll be on their website and all. Okay. Because I have way too many. I may go there rather quickly because we may cover it in other ways. And some of these documents will double up. So remember the 5 Ds. you want to redo it after a death or a divorce. Maybe your first healthcare decision maker has died, you got to change it, or change in your diagnosis or decline health condition back. Look at your form and redo it. Even if you don't change your advanced care directive, you can add addendums to them. Oh, shoot. You know what? The one addendum I wanted to bring, I didn't bring, but I will email it to talk about it. Because the way the advanced directives has set up, there are lots of rooms where you can fill in whatever you want. So it's not a form that we're going to checklist. It can be a narrative about who you are and what you would want them to know if you couldn't speak for yourself. So use the form and fill it out so that someone can get an idea of what you wanted if there's an area where you're not sure of how to fill it out. We're going to go through. Yes.
The previous slide said one of the D's was death. That means death of one of your one of your family members, or the death of your healthcare advocate that you had named. Yeah.
Oh, his question.
Oh.
They can't hear his question. They only hear the response.
Oh, okay. Repeat the question. Sorry. Okay, very much. So the question was, and the 5 Ds, one was death. So the death that we're referring to in that slide is the death of a healthcare advocate or the death of someone close in your family. You know, maybe that list of siblings and advocates. So that would be a time to relook at your advanced directives and who do you have listed on there, because a lot of the form, and those of you at home, if you don't have the forms, just take some notes for now. And when you get the form, it's going to make a lot of sense to you, because the first couple of pages of the Advanced Care Directive is really who's going to be your agent or your healthcare advocate if you're not able to speak up for yourself. And then it's asking for the name, the address, the phone numbers, things like that. So that if someone needed to get in touch with your advocate and ask them questions, they would be able to do it. You can name a couple of people in this area. You don't necessarily have to where they were from or how they're related to.
If you name 2 people, they have a different opinion about what should be done.
So if you name 2 people, you want to have a number 1 and a number 2. So number 1 is your healthcare agent or advocate, and number 2 would be who would win, like the runner-up in a beauty contest, or that kind of person. Often they both may know each other. They often will talk to each other, but you can definitely specify that that first person is the person who's going to be the one to make the decisions. And I'm hoping that you have made your wishes so definitive in this document, no one's going to have any options. They will agree on what you want here. But the slide is talking about talking to the doctor and family. So before, we always think, we want the doctor to talk to the family and let them know what's going on. Let them know that Medicare now will pay for an end-of-life discussion with your doctor. So make an appointment. Let them know that this is what you want to be able to talk about. So, especially with your primary care doctor, comes that he or she is going to be with you on your decision. And you don't know how many times patients will say to me, I'm ready, I want to go to hospice. And we have to ask the primary doctor 3 or 4 times to get a referral to hospice. Oh, no, you're not ready. Oh, no, you're not dying yet. And the answer is people aren't dying, when they got in hospice. They have decided that they do not want to do any more curative treatments, which is not the definition of dying by any means. But they want the benefits that hospice will give them. What if I do nothing? What's the quality of life? So as you do your forms and think about it, think about the quality of life, what is most important to you, what kind of treatment, what you can put up with and that you're not going to be able to put up with. What can you expect in the next 6 months or so? Where will that lead if you don't do treatment? And sometimes if I'm going to go forward with treatment, what are those side effects? And how will you be able to deal with the side effects and the change in your life? Think about milestones that are coming up, both with you and your family. Let your doctors know about those milestones so that they can also put that into a plan, the plan, if there's a wedding or an event that you want to be able to attend.
My question is, I had an end of life discussion with my doctor and I paid for it. How long has Medicare been paying for that?
Oh, I don't know how long it is, but it is part of there is a diagnosis code for that. So I don't know whether it was part of your, yeah, I'm sorry. She said, how long has Medicare been paying for an end of life discussion? Thanks, Rebecca, because I'll forget. How long they've been paying. I know it's been quite a few years, but remember, sometimes when you pay for a doctor appointment, you're paying because you haven't done your deductible and those things. So that's not, I'm not good at that area at all. So again, in the advanced planning process, you want to keep talking about, this goes back to the slide about goals, values, beliefs. So planning things out so that you're getting the education and resources you need to deal with your level of care that is at that time. The understanding of your health condition, what activities and beliefs bring joy to you and meaning. What are your hopes if the condition worsens? So what trade-offs are you willing to make? So it's those big questions that, and again, those are the things that can change as your life moves forward and your disease process move forward.
Question.
I'm sorry.
Where would you store or would you hold the document to know that it's available for ambulance or any situation?
When would you have the document ready?
Where would you have it located?
Oh, okay. I'm going to talk about that. There are a couple different documents. I know people that have a little go bag that has everything in it. When the document is done, you can scan it. You can have it in your phone. And then there's a second document, the POLST we're going to talk about, that you want hanging up in your house or on your refrigerator. So we'll get to all those, okay?
I have an answer. Medicare began paying for end-of-life discussions January 1st, 2016.
2016.
Okay.
Thank you. Thank you. All right. Very good. I will put that on my next slide. Thank you. Again, I've told you I have a big love of slides. So there are a lot of slides that say the same thing, but I want to get to start working on some of these documents. Increasing the likelihood that they're going to pay attention to it. So many times we'll say, oh, I've worked on all these. I told them I've got this done, and then no one paid attention to it. So there's a couple of things we can do to make sure that your wishes are followed. Choose a proxy that you know is going to be committed to honoring your wishes. Communicate often. When you see your primary care, bring it up again. You know, I want to remind you what I said about end of life and that I really don't want to have a long drawn out, or think again, as your situation changes, don't be afraid to bring it up, and sharing your wishes with your family and friends, stating them often. Make a video or an audio recording. This is also helpful if you have a large family. When you have a little video stating that, look, I really have always thought that when the time came, I would want to use the end of life option act, or whatever it is that you feel strongly about, and it's in a video and your family sees it, it has a really, really big impact, okay? And that just reinforces your confirmation of how you feel. A lot of times you asked about the documents. When you're admitted to the hospital, you're going to need to have a copy of your documents. So bring it with you then. And a copy is as good as the original. So as long for both of the documents that we're talking about today. Again, the best preparation is the people preparation. You can have all your documents, but if those around you know what's in them and know how strongly you feel about them, then you're going to have your wishes followed. Language matters. Be clear about it. Don't just say, well, I don't want to be in pain, or I want to live well. You have, or, be specific. I want to be able to go to the Dodger game, or if I can't get up in my lounge chair and play bridge, then these are the things that are important to me. It's those kind of things that we have to get to them. Did you have a question?
Yes, I think I heard you say you need to bring this document with you if you're admitted to the hospital. It was my understanding that once you fill out this form and give it to your primary care doctor, that it's put into your computer, and that, yeah, it's a good idea to put one into your phone, of course, too, but that it's in your records and that everyone should have access to it. So why do you have to carry it
Okay, so
around
her
with you?
question is, should you bring it, once you give it to your primary doctor, it should be there. The reason we like to have it in their phone or have a copy somewhere is because the one word you said, should. Yes, it should be in there. And you may not always get your primary doctor. When you get admitted to the hospital, your primary doctor may not be taking care of you. It could be on a weekend. You could have ended up in a different hospital somewhere. So having, and it's not that long of a form, but even if you take a picture of that one page that has your wishes on it and that has your signature, it's going to be something is better than having nothing there. And especially when we talk about the POLST in a minute, you'll see the difference in them and why it's good at least to have an extra copy. I know you've got a big enough purse that you could fit another piece of paper in there.
Look at my purse. My help.
I have the same problem. So
they'll refuse to take my purse.
yes, exactly. So take a copy or make sure you know where it is. But yes, I agree. And actually, in California, you'll see California has an Advance Directive registry. So once it goes in, it should be uploaded to that registry, and all of California hospitals are able to access your Advance Directive. But I even have a better document coming up, the POLST. So first, we're going to determine who. Now we have two sets of Advance Directives. One is this cute little one that's really, it's very easy to follow along. And what I like about this one is that the California Advanced Healthcare, it really explains what some of the terminology is. If you're not in medicine and someone's talking about cardiopulmonary and resuscitation, a lot of people don't understand what that means. And then the other one that we see a lot looks very legal. So, but the first thing you're going to do is choose who is that family member or decision maker that you want to list as your healthcare advocate, okay? They can't be a doctor and they can't be someone who works in a hospital or a clinic. So it's great, but when you say we want to list more than one, we want to make sure it's not someone that's going to, inherit lots and lots of money from you too. So we want to make sure that it's someone who is not in some way going to be responsible for a lot of things, okay? And then what are these decisions that the healthcare, so this next slide is what the other form Advance Directive looks like. So designation of an agent is the healthcare advocate. So don't get confused by all the terminology. Agent, advocate, what else? What are some of the other words you've heard them describe? Candidate, yeah, candidate. Yes, ma'am.
Do you need to have the signature on that form notarized?
With what?
Notarized.
The notary?
Yeah.
No, in California, it doesn't have to be notarized, but if you don't have your healthcare advocate to sign it, and the same thing with the POLST, if you don't have those two people there to witness it, then you might as well just do a notary and have the notary there. So let me get to that end and you'll see, okay? So right now, all you need on the form is the name of the person you want to name and their address and a couple of phone numbers for them. They haven't switched over to all the email addresses that everybody else asks for all the time. And then at the bottom, it says, that this agent is authorized to make all healthcare decisions for me, including decisions to provide, withhold, or withdraw artificial nutrition and hydration and all other forms of healthcare to keep me alive, except as I state here. Now, in each of the other forms we're going to talk about, yes, it has written down what these things are going to do, but there's always the except. You can cross out what you don't want in there, and you can use that area to fill in. So if you're working on it now and you want to write some notes, that's fine. But take a clean one, and if you don't have one or you want to update it, you can add or change any of this.
I saw a program on public television where somebody, McCann, I believe, was about 30 years old, and she had to stay as a vegetable for 7 or 8 years because the courts wouldn't let them pull the blood. Now in California, I guess that's not true anymore.
I'm not sure what the exact, she's asking about someone stayed so many years as a vegetable because someone wasn't able to pull a plug. And then it goes back as to who is making the decision. Are there family members trying to make the
The
decision?
judge made the decision,
Yeah.
8 years of vegetable.
Yeah, but there are other courts they can go up to. I don't know about the case, so I really
You don't know the
can't say.
California law, and
No,
should
I
check.
know the California law, but it's all about who's made the decision. And if there is anyone else, a relative on this hierarchy of spouse, siblings, other relatives that could speak up and go, oh, I know Jane and I want to interject here. This is not what she would want. So then you always get people stepping forward and then going
But
to
if you
court.
have an advance directive and you put in there that you never want that, then they have to honor it. They can't take you to court. And
Well, no, I wish I could say that that's true, but there are always going to be circumstances on a piece of paper where someone can go to court and say, well, in this situation, if we withdraw, I think the more that you have actually written and said, this is not, if you filled out a document, especially if it's done within the last 6 months, that said, that's not what you want, that would really make a big impact on a judge's decision. Remember we go back to Karen Ann Quinlan, who
Yeah.
remembers Karen Ann Quinlan,
Oh,
right?
yeah.
Right, a young woman, she didn't have anything written down
That's
anywhere.
awful.
So when you have something that is said, this is what my values are, this is what I would want or wouldn't. And so I think it's much more unlikely, but you're right, there's nothing to say, especially when we have a system now where not all of our hospitals are publicly run. There are a lot more religious institutions, and so they may have other value systems that you don't have. So this is why it's important. The more that you can get onto paper about your wishes and what they are, the better you're going to find that not only will your advocates and your family stand up for what you believe in, but the courts will too. And that's where it will end up going to. So let's go back here to the form. It says they can only give information. The medical providers are not going to make a decision. They're going to say, if we do X, this is what's likely to happen. We can do X or Y, and these are the outcomes we would expect to happen. And then they're going to leave it up to your agent, healthcare advocate, to make that decision. So first, what you want to put on the form is, do you want your advocate to make medical decisions on their own without any input from others, or make it with input from others? I think this is, is not based on any reality, because they're going to have input from the medical
Where
professionals.
is that question on this?
It's page 7. It's on after on all the ones about, I'm sorry, I skipped way ahead, didn't I? It's way on,
Page 7.
yeah, let's go back to page 3 here, where we're at 1 point. It says part 3. Okay, so part 3. All right. It's page 3 on the legalese one. And where is it on our, on the
Thank you so much.
black and white one that says okay, who do you choose? And then the next part is, do you want your medical decision maker to follow your wishes if you're not able to speak for yourself? So,
Is this at the bottom?
yeah, so it's page 6 on the, you guys have a colored version. And then there's another one that's the legal one. It says advanced healthcare form at the top, page 3 of 7. So basically the question there is, you know, do you want them to make decisions with input from others, which I think is kind of like, yeah, of course. And then on the California Advanced Healthcare Directive, they're trying to get you to think about what quality of life differs and how it's different. So what are some of the most important things in your life? Family, pets, hobbies, working, religion, caring for yourself and being independent. So I asked you to list some of those. And even if you have one of the other kind of forms, I would very much suggest that that's some of the things that you want to put in these forms when it says, you know, what's important to you, what you want. Fill in some of these things about yourself so that whoever's reading these forms, and if you're not able to speak for yourself, that they're going to get an idea of who you are and what's important to you. So remember what I said in the beginning. Yes, there's a lot of words on each of these forms, but you can add your own words about yourself, who you are, and what you'd want to be able to do and what's important to you. Okay. And then this is just, and then it's going to ask about organ donation. Okay, well, okay, so then part 2 is this. I do not want my life to be prolonged, even if I have an incurable or irreversible condition that will result in my death within a short time. Or 2, become unconscious to a reasonable degree of medical certainty, or I will not regain consciousness, or the risk and burdens of treatment outweigh the expected benefits. So that's a lot in a little paragraph. So it's part 2 on page 3 of, I direct my healthcare provider and others to not to prolong my life or to prolong my life. And before we go any further, then it talks about relief from pain. So this whole section and the other wishes is that area where you can check off, but say accept or what you want and would want. I wouldn't advise anyone to just go with, hey, I'm going to check off this first one. I would be detailed about what you want and what you wouldn't want.
My doctor told me that if you need to be resuscitated, you're already dead.
Well,
And
yes.
Maybe you wouldn't want to do that depending on other circumstances.
Okay, we're going to talk about that in a minute. She's talking about resuscitation, and we're going to talk about that in a little bit. Okay, so basically these part of the documents are talking about what do you want at end of life, and it makes the point is, hey, read this whole page before you make a decision. You may have already decided what you want, but we want you to read the whole page before you make a decision. And what I want to do for a minute too is go back and look at what is CPR and what is resuscitation? What does that really mean? And when we talk about artificial nutrition, what is that? And what are we really talking about? And that, I think, can help a little bit in determining what you want or don't want. So, and what you matters for medical care, and for most people, it differs from other people. You know, in the one Advanced Care Directive form, they're very descriptive in what they're talking about. Where are you right now in the healthcare? You know, and they use the line to say what's important, what's not important, and how would you feel at end of life. So I think what this form does is really helps you to really get to a point where you're understanding what is the important things and how you can best be able to express them to your advocate. Okay.
The slide for the part that you're talking about for those online.
Pardon?
The part about the
Oh, yeah, so we're on the, it's called the California Advanced Healthcare Directive, and it's on page 9.
Do you have on your
Oh.
PowerPoint, you have a slide for that?
Yeah, it's, I think that's the slide I'm on right now. Yeah, it's right here. Yeah, it's exactly where I'm at, okay?
Page 10.
Yeah, and then on page 10, balancing quality of life with medical care. I don't have a picture of that one though. But let's talk a minute about CPR since we brought that up in resuscitation. Because when we talk about what we want at end of life and what's going to happen. So yeah, all those medical programs we watch, they do CPR, they put a tube in the throat, and about 20 minutes later, the tube's out and the patient's talking. And that doesn't happen in real life. And we look at some of the numbers on CPR, it's 90% effective on TV, but only 18% in reality recover from CPR. And only 40 to 50% of patients get a heartbeat back initially after CPR. Only 15 or 20% survive and leave the hospital. So, and even with that, many patients are older patients. They're having, they may have had good brain function before, but they won't have all of their mental awareness afterwards. Survival drops to 5 to 12% in those over age 70. And if you're already very, very ill, there can be as low as 5% of those who survive. And if you're having CPR, you're going to end up on a ventilator with the tube down your throat with the oxygen going there, feeding tubes, which we'll talk about in a minute, and poor neurologic. So yes, it's a very important question is if you want the CPR that's involved in resuscitation afterwards. So there are patients that do much better with CPR. Maybe those that are having a simple cardiac issue, those with holes in the heart, or those that have had a genetic cardiac issue, they tend to recover much better from CPR.
May I ask you, after major surgery, if you needed CPR, you have statistics about that?
After major surgery and people need CPR, yes, again, depending on what the surgery is for. Many times patients may need CPR after surgery for an issue, but again, it depends on the condition of the patient before CPR.
So if you're in great shape and you're 85 and you have major abdominal surgery and they need to do CPR, what do you know what the statistics are on?
Well, I just said over 70, it's less than 5%.
So it's more your age.
Yeah. Age and the degree of illness in the body. Okay. So again, we talked about storing for a second. What are we going to do with this advance directive? So making a digital or video copy is important. There are a number of services online you can use, Medical Alert, My Directive. And then again, there's a, do I have a slide there? No, there's a California, I swear I did it this morning. There's a California Advance Directive storage area, and you can upload it. I thought there was a slide for it. I'll send it to a follow-up to Rebecca, because there's a couple things I want to send her about storing it with the California Advanced Directives. Okay. Yeah, I see that we have the U.S. Advanced Care Plan Registry. So it's a California Advanced Care Plan Registry is what it's called. So let's talk about the POLST for a second, because a lot of times you go into the hospital or the doctor and they're going to ask, do you have an advanced directive or do you have a POLST? And the POLST stands for Physician's Order for Life-Sustaining Treatment. And every state has one. There's a big push right now to get a national, because there's a coast and there's a most medical orders in New York State. So there's a big push trying to get it more nationalized and get a version. But this is the California version. They're supposed to be bright pink because you're going to be able to identify it right away. If a patient is currently on hospice, we have them have these filled out and we hang them on the refrigerator. because the difference from this and the advanced directives is this is going to be signed by your physician or physician's assistant or nurse practitioner. So it's like a doctor's order. So when you say, oh, and call the EMTs to your house for someone in your house, and you say, these are our pulse. These are what the doctor, these are the wishes that we've agreed to. So you have a much higher chance that your wishes are going to get followed in an ER with a POLST on board than just the advanced directives, okay? So let's go over this a little bit and you'll see it's the same thing. Usually it's a standardized form, and we recommend that anyone with a terminal illness or an advanced disease or a chronic illness have a pulse, not a pulse, but a pulse, POLST. I think I have an accent sometimes. And anyone with advanced dementia, people are very elderly or frail. If you're in hospice or a skilled nursing facility, or you want to be do not resuscitate, you don't want CPR, okay? So you can complete it, you can start to fill it out, but again, it has to be signed by a doctor. So if you got the form with you there, fill it out with what you want, and then take it to your next doctor's appointment and say, you know, I want to have one of these. At any point, you can throw out your advanced directive and start it over. If you have a pulse, you can say, no, I decided I want to do some other treatment, rip it up and start over again. So none of these are permanent documents that you're wedded to after you fill them out. They can all be redone and started over again. But these are physicians ordered for guided treatment. They can guide your treatment and your care about what you want in terms of antibiotics, resuscitation, nutrition, even hospitalization, okay? So it's instructing emergency personnel to administer or forego treatments. But just because we're not going to do treatments doesn't mean we're not going to care for the patient. We're not going to make sure that they're comfortable and they're getting pain relief and they're able, you know, to breathe comfortably. Doesn't mean we're not going to do anything. We're just not going to give treatments that are going to try and cure anything. We're going to keep them comfortable. So it is a state document. So we say post it near the patient, hang it on the refrigerator, hang it near the door, okay? We say that usually it's for someone where if they died in the next 12 months, it wouldn't be a surprise. But then again, hospice, we say the patient has to be 6 months or less. But there are many, many patients that are on hospice for a year or more. So at the end of 6 months, we reevaluate. If we've seen a definitive decline, whether it's a decline in 6 or 8 other measurable areas, then you can re-up again when it comes to hospice. What, you had a question?
Where do you get this form?
You can get them at the doctor's office, at the hospital. We have some for you today. There's some white ones. Just fill it out and then take it to your doctor's office and have them get you a pink one. But the pink, even if you have a white one and it's signed by the doctor, it's still good. It doesn't have to be pink to be good. It just has to be filled out correctly and signed by a nurse practitioner, a physician's assistant, or a doctor.
If your doctor is terminal and dies, would the pulse still be good?
Wait a minute. The question was, if the doctor was terminal, I don't care about the doctor. Yeah, yes. We've all had, yes, the signature would still be good within the time period. But I think at that point I would have, someone else from his office sign it. I don't think anyone's going to know per se in the emergency room, but yes, it still was his wish her wish that this was the order, but I would probably, hang on one second. There's a couple more questions, then we'll go forward. Go ahead.
40 minutes as well.
What?
We have 40 minutes.
Oh, okay. Yeah, we're good.
Is palliative care and hospice almost the same?
Yes and no. Palliative care is a medical specialty where they're working you know, many people have a number of different chronic illnesses. Palliative care is working to manage all the symptoms of those numerous illnesses and how they all work together with one patient. That's what palliative care does. It's caring for someone and treating all these symptoms that are occurring, whether it's from the multiple illnesses or from the medication, but they're not working on curing anything. Hospice is specifically meant for patients and families as a patient nears dying. Okay, hospice has a lot of benefits in this. Palliative, you still have to go to them and you have to see them in their offices. Hospice comes to the patient and the family. So whatever medication you need during hospice is going to get delivered to your house. If you need a hospital bed, if you need a commode, if you need a wheelchair, all that stuff is going to get delivered and is covered by Medicare and most insurances. The RN's going to come, I know I have a slide of this coming up, but the RN's going to come to your house and visit at least once, maybe twice a week. You're going to get an aide that's going to come and help around the house. So whatever you need, and if there's an emergent situation, they're going to be there on the clock, and they're available 7 days, 24 hours. So why aren't people going on hospice sooner rather than later? Tell me that.
Because they think they're gonna die if they go on hospital.
But I think more often than not, patients don't think they're going to die. Well, they think they will die if they talk about it, but that's not true. That's not true. But I think that, you know, there's always this, like I say, often I have 2 patients right now that are asking to go on hospice, and we have to keep going back to the doctor again to say, will you please send a referral over to hospice? Sometimes I just tell the patients, call the hospice up, tell them you're ready, and let the hospice call the doctor, and then they'll give the order.
So
Okay.
What's the cutoff between being really a patient for the hospice or having the treatment through the general approach?
Oh, it's totally up to you and your medical providers what the timing is and where you are. It's totally different for each individual. For hospice is if you have a life expectancy of 6 months or less. And it can go with all your different conditions. You know, someone may have lung cancer, but they're ambulatory and getting about their day, and maybe they wouldn't qualify, but they also have chronic heart condition, and they have, you know, 2 other listings. You know, we all have these problem lists that go on and on. So it's really a combination of how those things are working together. So the first thing that they're asking you on the pulse is cardiopulmonary resuscitation. Okay, so that's the CPR that we talked about. So it's a small box, but it's asking you, do you want CPR or do you want them not to attempt it? And I like what they put afterwards, allow natural death. So it may be that someone's heart is slowing down or CPR. Do we want to give them other medications, or do we want and do CPR? Or do we want to start the, hang on, I'll go here a little bit. Or do we want to just allow a natural death? So when we talked about the statistics before, this can give you a little bit of the differences between what we see in certain conditions when we do attempt CPR and when we don't attempt CPR in terms of a peaceful death, what we want to allow the patient. And that's where it goes back to really talking to family and friends about, hey, where do I want to die? And what do I envision that to be? What do you want and do you not want at that point? And I do this. I work with medical aid in dying, and I know that people are able to choose when and how and under what conditions. Okay, so when you go to B, medical interventions, is the choices are really, there's these 3 boxes, like we're at a fast food restaurant here: full treatment, selected treatment, or comfort focus. And I think this is the more important part in understanding what full treatment really is, selective and comfort focus, and what we're getting with each of those. So what I'm really doing for those at home is I'm going through the steps on the POLST, the POLST form, and what they are and what they really mean, so that I think I know I have. This goes back to the CPR again, what some of the rib fractures and chest injuries. I swear on every medical program, everybody always has a pneumothorax. Something happened in the ribs and the lung is collapsing. We have to do something. But these lung damage and the rib fractures very much happen during CPR. You can hear it. You can hear the ribs of the sternum breaking. And often that can cause either air in the lungs or blood in the lungs. And that's when you have to put a tube in that space to drain it out. So that part of it is true, and it happens. And if the CPR is delayed or not enough oxygen has gotten to the brain, that's when we do see a brain injury from that lack of blood flow to the brain. And so people who do survive it can have cognitive memory loss or a coma. We also see sometimes damage to the liver or the spleen, just because some of those smaller ribs that we don't all see are up in there. And those patients, even though we see them all hanging out in the ER on TV, they end up in the ICU, and they could end up on ventilation on breathing machines for quite a while, and then end up in rehab. So, but the people that do well are those that get into emergency care right away, aren't down very long, and maybe younger, okay? If a patient wants death with dignity, choosing do not resuscitate or a pulse it's not a question of giving up, but choosing a peaceful, natural death, as opposed to something a little more traumatic or, makes great TV, but not how we all want to die. So completing the POLST is voluntary, and it doesn't replace the Advance Directive, though they both pretty much say the same thing. I think the Advance Directive gets to name who the person is. So I wanted you to become familiar with what they both are, and that the POLST, I think, gets listened to a lot more, especially in California, in the ER and around hospitals these days. Go ahead.
I have a friend who is in the situation of dying at this moment. But she said to me that she wants to take a pill. I don't know if California approved this or not.
Yes, we're going to talk about that in a minute. Not taking a pill, but how we can control our own dying when the time comes. Yeah, I'll get there. Okay, let's talk a little bit about okay, anybody have any questions about the full, selective, or comfort focus?
I do.
Okay, I'm gonna.
On page 10 of the it has trial life support, three options, trial life support treatments. To try the ones that my doctors think might help, but if you don't work, you don't want to see a life support. And the third is the no, a life support. So is the second one like analogous to the one that you said about the selective option?
Yeah, tell me which
Okay,
page again you're
10,
in.
Page 10
Page.
of this.
Yeah, and then I know they're probably an organ donor. My position.
Is it page 10, the three boxes? Yeah. Trial life support treatments.
I know, and I'm not seeing the same one. Yeah. Okay. Trial support. Try a trial of support.
That my doctors say might help.
Yeah.
Or I do not want life support treatments. So that middle one, is that what is analogous to, parallel to the selective option that you mentioned on the other form?
Yeah, I think it is comparable to that. And again, it's like but what it doesn't explain to us in a good way here, what is life support? Is life support then the breathing machine and all the other equipment? If you want, I want life support treatments, but I don't want a ventilator, you could specify, specify that.
Yeah, right above the choice area, it says life support treatment can be CPR, a breathing machine,
Feeding tubes, dialysis,
or transfusion.
or
So you
trans.
could write in a paragraph, you know, which one of those you
Right,
would want,
right.
which
What
one you
else would you know about this choice, or why did you choose it? So you could use that paragraph to say, no, I wouldn't want the breathing machine, but I would do transfusions, I would do feeding tubes. Okay,
Okay.
yeah.
Summarize for those online about what you just talked about.
Yeah, so what we were just talking about, and actually we're going to talk about a little bit more now, is that in both of these documents, it's asking which of these treatments that you would want, okay? Whether you want all life support treatments, and in the advance directives, it talks about, it considers life support as CPR, a breathing machine, or a ventilator. We also hear them, the ones where it's pushing the oxygen in and you have a tube in your throat, as opposed to the ones where you have a little tube in your nose and it's just giving you supplemental oxygen. So a breathing machine is breathing for you. Feeding tubes, dialysis is where there's a big tube taking blood out of you, cleaning your blood, and then putting it back in, doing the work of your kidneys for you. And transfusions are giving you more blood. Sometimes when we're ill, our blood, the volume of blood tends to go down. We don't have enough blood, or we don't have enough platelets, and we can supplement that with transfusions. So it's asking you to check the one you agree most with. Do you want to do all these treatments and stay on life support, even if there's little hope of getting better, or living the kind of life I value, or do a trial, do a little bit of life support that doctors think may help, but I don't want to stay there if they're not working. I think that's the part of this statement that gets kind of like, well, how much is a little, and who's going to decide if it's not working? So I think you have to use that paragraph to be a little more, and that's why something like the POLST is a little more definitive, where, and again, I would say use both of these documents if you can, so we're not leaving too much up to question, but there are always going to be little holes. Or I do not want life support treatment. I want to focus on being comfortable and prefer to have a natural death. Yeah, as we said earlier, I think I would update at least every year. You don't have to redo the whole thing. You could, at the end, you could write the date and say, I've reread this, I wholeheartedly support everything that's in it. Or make a couple of changes. If you make a change, put the date next to it. And again, you could rip it up and redo it at such a point that your health changes so much that you want something new and different. Okay.
We have a question online. Deborah, go ahead, ask your question.
Hi, thank you. Now I have two questions, but the one most relevant to what you're talking about right now, how long, in your experience, how long does a trial of life support typically last? Like if you said, yeah, I want to do a trial, but I only want it to be 2 days or something like that.
I don't think there is such thing as a trial. I've never heard, definitely they may put someone on life support and say, okay, let's see if we're seeing that they're using less in the next few days. And again, my background is oncology and hospice. So it's not like I've spent a lot of time in ICUs and setting up the machine, but I think when you get into this area of a trial and how many days and then who's determining, definitely if someone has started breathing on their own, if it's been an accident or something like that, then, oh yeah, we can take them off life support. But I think if someone has been chronically ill and has an illness that has caused this, so it would very much depend on the situation and the patient and how ill and how much damage has been done before that. What was the other part of your question?
The other part had to do with the POLST, and Is the POLST the same document that folks, that there are some recommendations that you have stuck to your refrigerator so that if you do have
Yes.
emergency personnel coming in? Okay.
Yes, so this is exactly what everyone's asking. Do you have a pulse filled out? Is it, is it up to date? Because I think that's the one that you will find that people will pay attention to if you have it signed and updated. And it does do a little bit to explain what some of these procedures are. And again, as you change, you can change these documents. We got one more question in the back, and then I'm going to go through artificial nutrition a little bit.
I have a question about if your heart stops beating, not that you need CPR to breathe, but if your heart stops beating and they zap you on ER, is that something that would be mentioned here?
Yeah. Okay, so let's understand CPR. CPR is cardiopulmonary resuscitation. So when your heart stops beating, then it's not sending blood to the rest of your body, which includes your brain, okay? So when that starts happening, then you're not able to breathe anymore because there's no blood getting to your lungs. So neither your heart or your lungs aren't working. And the blood, which carries the oxygen, is not getting to your brain anymore. So they'll start the compressions to see if they can move the blood around. So by compressing the sternum, you compress the heart, and that starts sending the blood back out to where it needs to be. At the same time, they're giving medication and hoping that they can get the heart restarted. If the medication doesn't work to get it restarted, then they'll try with electric shock. But how long the patient has been down and not gotten oxygen or to the rest of the body, can be very critical. But sometimes we have patients, and look at some of these basketball players that have come back and done really well. So it really depends on the condition of the body. But yes, it is cardio, the heart, pulmonary, the lungs, and all of that at the same time. So let's talk a little bit.
Question. I was in a plane where somebody collapsed, so they used the defibrillator to keep them till the plane could land. At that environment where you don't have the whole medical team, and probably your brain is not up to speed to say ENA, do you just let it happen because it keeps you alive, or do you pick up the pink paper and say, here are my...
No, I think in that situation, it just depends on the situation. Now, remember, a lot of those defibrillators, though, when you put the rubber parts down, it's like your Apple Watch. It reads what's going on. So they're not just putting it on and then doing the zap. It actually reads the heart rhythm and says when you need to zap the patient. So it wouldn't, it's not something that somebody independently is looking at, like in the old days when we had to know what the rhythm was and know whether the patient needed to be cardioverted or not. So a lot of times the new machines are great that way, that they can really read what's happening and then give it. But I think in that situation, you want to do whatever you can that's the right thing for that patient at that time. Let me get through this next little part, and then what is it? I'm sorry.
Real quick question.
Real quick. Okay.
Yep.
20 minutes. Okay. 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 All right. Let me just I wanted to, I'll go to you first, the next, I promise. So I wanted the other big part, because we talk about cardiopulmonary resuscitation and artificial nutrition, because that's a really big part of it, is what else do we, when we say we want to keep the patient alive and comfortable, that's the other part of it. Once we have that heart beating, so what does that really mean when we're giving artificial nutrition? Is it long-term? And again, the tube is going to ask, is it a trial period, including feeding tubes, and don't give any at all? And there's room here on the POLST form and on the Advance Directive to say additional orders or for you to write something in particular that you want. Offer food by mouth if feasible and desired. And this is also an important point when we talk about dementia. If you have a patient who has dementia and has stopped eating, do we want to hand feed? Do we want to force them to give food? So it's, when we talk about people being able to die naturally and comfortably, that's an important thing that you want to think about putting on your pulse, okay? So what does it mean, the different types of artificial nutrition? So when we talk about enteral feeding, it's tube feeding. So you either have nasogastric, where it's a tube that goes through the nose, and we give tube feedings that way, or PEG, which is a tube that goes into the stomach, or J-tube that goes into jejunum. Okay, parental is IV nutrition. Sometimes it looks like yellow. They put yellow in the bag, or that's called total parental nutrition is TPN. So there's long lists of risks and benefits then, but it can prolong life. Definitely, you've heard of people in earthquakes and all, they haven't eaten for 7 days, the baby that lived for 10 days and all. And we all know whenever they tell you, oh, you can't eat or drink for 24 hours, we think we're all gonna die right then because we're not eating and drinking. So we know we can go longer than we think we can without eating and drinking. But the first thing that happens when we stop eating and drinking is it's really the liquid that we have an issue with. The kidneys are going to go into kidney failure first, and then coma from not drinking. It's the liquids that we have a problem with. So and we know often that this the tube feedings cause diarrhea that can lead to other side effects and all. So there also causes, by doing the tube feedings too, we have a lot of patients that have trouble eating and swallowing, and then we have issues with aspiration and aspiration pneumonia. So there's a lot of things that play into the risk there. And then, sometimes emotionally we feel like, oh, we're doing something. If we don't do anything for a patient, if you put an IV up and they're getting fluids, well, at least we're doing something for them. But when you take someone whose body is already beginning to shut down, and we start putting fluids into them, so where are those fluids going? We know the heart and the lungs aren't working very well. So now all that extra fluid is causing difficulty in breathing. They can't process that fluid because everything's shutting down. And now we've caused more discomfort for the patient because we've added this extra fluid on. So we want to look at everything when we talk about keeping people comfortable. Oh, this is the side effects of what I just talked about. Discomfort and infections from all those things, aspiration, pneumonia, and then the metabolic imbalances that can come from the blood sugar or liver functions. And a lot of times our patients are a little bit confused. And then if we put tubes in, they're going to want to pull them out. So then they're going to ask about restraining them. So that makes things even more difficult. So it doesn't always prolong life. We want to be able to improve the quality of life the best we can. Okay. And with the least amount of interventions. Oh, this is another do not resuscitate. It's just a one form. It's not as many pages as what we're dealing with here. So that's what we're asking about when we talk about artificial nutrition. And so before we check yes to one of those, we really want to understand and put some limits as to, if we were going to put short term, that would be one area where I say short term, because once you get that G-tube in and you'd have to do a surgery for the G-tube and the PEG, it's really, really difficult to get rid of that. So start with an NG tube and get a little bit of feeding, but really understand what the long-term outcome is for that, what you're looking forward to trying to get done. What was your question, sir?
Okay, real quick one. You said that we need to keep the Advance Care Directive updated. We make a change. We change the date.
Yeah.
The advocate and the backup do not date theirs, but the witnesses do. So when the witnesses sign, when you do a change, does the witness have to also update?
It would depend on where you're making the change. Like I say, the more important thing would be you read through it. Maybe you did it a year ago and you read through it at the end of the year and said, hey, I really believe here, I'm still standing by, this is my advance directive and this is what I would want. Yeah. Yeah, you wouldn't have to have your witnesses re-sign it at that point,
Okay.
no. So quickly, let's hit on some of those other end-of-life options. She talked about, you know, being able to take a pill so pursuing all end-of-life life-sustaining treatment, whether it's antibiotics, whether it's artificial nutrition, or CPR. Again, you can designate or delineate specifically what parts of those. There's such a thing as having somebody used to call it, it's not a slow code, but a chemical only. Someone has a cardiac arrest, you can ask them only to use medications, but not to do the machine, not to shock the patient, just to do what they can to try and bring them back as naturally as possible. At any point, anyone has the right to discontinue or decline any treatment whatsoever. So we all have that right at any point to say, no, I'm done. I don't think I'm gonna do that. Palliative care, we all want to ask for palliative care. When I started nursing, there was no such thing as palliative care. But if there's too many things going on and your doctor, you feel like your doctor doesn't have a handle of whatever 25 medications you're on, ask for a palliative care consult, but know that you're going to go there, they're going to look at everything and say, look, it makes more sense for you to be on this as opposed to all the 10 other things you're taking. What's the most important thing? And you know, there's a certain point in life where we may not all need to be on cholesterol medication. So take what you need and what's going to work best for you. But pain management, everybody, I mean, make sure that you're having good pain management. Don't just say, well, you know, I'm older and this always hurt, that's hurt. Because the continuing pain causes stress on your body and puts out these other things that makes your body tense up and you're not getting as the quality of life that you should. So mention your pain, make sure you're getting what you need for your pain, and then take it routinely. The more you take the pain medicine that you need and don't let it wear off, take it again before it wears off, and you'll find that you'll feel much better and you'll be able to do much more. I can't tell you how many patients I see one day and go over all this, and then, you know, the next time I see them a few days later, oh, I feel so much better. I'm doing so much better now that I've taken it, and I can do more than I thought. But easing your pain is a priority. Even though a big part of my practice now is medical aid and dying, the first thing we ask about is, are you in pain and are you getting your pain well managed? Because we don't want anyone using medical aid and dying who hasn't really addressed the pain appropriately. So let them know, be as specific and thorough as you can, and get a pain management program that works for you. It's just really, really important. All right, now, hospice. When we talk about a hospice, people think, oh, well, you've got to be dying. It's expensive. It's only for cancer patients. So, and it's only in hospitals. So most hospice in this country happens at home. The doctor refers you to a hospice. They come to your home or assisted living or some kind of facility. They don't go to hospitals. And like I said before, all the care happens at home. Okay, so 6 months or less, not all hospice patients are actively dying. I had many, many patients who maybe have a recent cancer diagnosis, but decided they're not going to do any treatment. They're going to go and live their life, and then they're going to have their symptoms managed. Pretty much everything else I've said before. You can go off hospice at any time. I've had patients go, you know, this clinical trial came up. I'm going to try this clinical trial, and you can go back to onto hospice at another time. And if you're not happy with your hospice, let someone know and you can change it anytime. It literally is making a phone call and you can switch to a new hospice, okay?
On that last thing, at the
Yeah.
bottom,
Yeah.
it has the acronym EOL.
Oh, end of life options.
you,
Be
thank
sure
you.
that you're getting the end of life options that you want. Okay, I'm gonna go through this quickly because I only got a little bit of time, but I'll stay as long as you need me, okay? You can change the benefit, that's not really matter, but it's 90, 60, 90 days. So like I say, I've had hospice patients that were on like for 2 years, but there's a lot of benefits, there's volunteers and bereavement and home health aides, and there's a lot involved with hospice. All right, sorry, I was trying. What difference between palliative and a hospice? They both offer comfort and higher qualities of care, but palliative is for any stage and hospice is really for the last 6 months. So they're all paid for for insurance.
Really?
Yeah, you can get insurance and Medicare to
will
pay for them.
it.
Medicare won't pay for palliative care.
Hospice?
Yeah, Medicare pays for hospice. Yeah. But Medicare is hospice. Yep. I have more of a problem with patients that only have insurance because they don't have it. They're not as able to move back and forth. I want to talk about the medical aid in dying quickly because we covered all this just to touch on it quickly. But when you ask about one pill to take, medical aid in dying is legal in 11 states. 75% of Californians said they agree and support it. It's just one of those things that is available. And you have to have 6 months or less, like hospice. You have to have 2 doctors that agree. So one doctor who's the prescribing doctor, you see them twice. And then the consulting doctor you see once. We do it all by telemedicine here in California. And then they'll prescribe a medication, which is actually 5 medications combined in one bottle. It all comes as a powder. And then you drink the medication if and when you want. Some patients never take it.
Is it horrible?
It's fairly bitter. We put a little bit of simple sugar in. And we have patients take some anti-nausea medicine about a couple hours before. Pardon? No, it's not legal in United States. Canada, you can do either or. You could get an injection or you drink it. But some of the European countries will do an injection, but no, in all of the United States, we were only allowed to use the GI system. So you can drink it, or for patients that have issues with swallowing and that, we do a rectal tube. And then I put a tube in, it's like a big old Foley, and we attach a 60cc syringe, but the patient has to push down on it so the medication goes into the rectum and then is absorbed, but we can only use the GI system.
What's the time frame till it really shuts off your heart?
Okay, so within 4 to 8 minutes, the patient falls asleep very gently and peacefully. They fall asleep. And then anywhere from 15 minutes to 4 hours, the respiration and cardiac activity stops. It's very, very peaceful.
The patient has to be able to drink it themselves.
Yeah, so we mix it up. It comes as a powder in a bottle. We'll mix it up. Like I say, we give some.
What if the patient not able to drink?
Then we have to do it rectally. So either they have to be able to drink, or they have to be able to push down on the big syringe. Yeah, it's not injected, but we put a tube in the rectum and then they push down on it. So again, it's absorbed from the GI system. So we always want those patients to still be able to drink a little bit or eat a little bit so that those receptors in the GI system are able to absorb the medication. But when we first started, it was, we used Seconal, 100 capsules. Now it's, digoxin, morphine, amitriptyline, phenobarbital, a lot of drugs that work really well. I think that's really, let me get last couple slides, we're done. The majority of people that use it have been enrolled in, are enrolled in hospice. We want everyone to be in hospice so that all their symptoms are managed. It's really, it's not saving any money because again, all these people are already in hospice, they're already actively dying. So it's not like an insurance thing where go, so they're actually getting all their other treatments. So Oregon's had it over 40 years and there's never been any issue with insurance company. Wills, contracts, or insurance are not affected. And the death certificate states the underlying disease process. So if it's heart disease, if it's cancer, if it's Parkinson's, that's what's on the death certificate. So it's not suicide. We don't call it assisted suicide or anything.
Can you legally go to another country and get an injection if you want to?
Yeah, you can go to Switzerland and yes, I have had patients who went to Switzerland. Yes, I have had patients that have gone. So if you ask your doctor about it and they say no, they won't do it, or I have a lot of patients say, oh, even they said it's not legal in California. It's been legal in California since 2016. So you can ask someone like me, there's a couple of other organizations, just ask them to refer you to a doctor who will do it. And make sure that they put it in the medical records that you ask about it, because that counts as the first doctor visit. So make sure it's, so, oh, these are the drugs right here. So the Reglan, Zofran, and then the medication. If you have Alzheimer's, it doesn't, you can't use medical aid in dying.
Oh, which is a shame.
Why?
Well, think about it for a
You don't
second.
have a right mind. You can't read. You can't read.
Hello, everybody. I would appreciate your respect and allow Karen to speak. Thank you.
Okay, think about it for a second. It's about the patient. The patient is making the choice to control their own death. If they have dementia and they're not able to make their own decision, then that would be the whole issue with it before was, oh, somebody can coerce you into doing this. So that's why we have all these safeguards to say, no, it's the patient's choice when and if. Sometimes they get the medication, or we always keep the medication, but you get the prescription and they decide not to use it. So it's about the patient's choice.
If you have dementia and you have in your advance directive, I don't want to be alive with serious dementia, can you go to another country and get an injection? Can't do it here, but can you do it in another country?
I don't think so. I know of patients who've had early dementia, had early Alzheimer's diagnosis, and left the country and was able to get something in Switzerland. But you can't do it here with Alzheimer's.
It has to be early so that you can.
You still have to be
so they can
early, right?
Justify that you made the decision.
Exactly.
Nobody wants
Any
to
country is going to want to know that you've made an independent
Yeah.
decision.
They don't want to
So what, wait 1 second, let me say, if you do have a history of dementia, Alzheimer's in the family, if you look at the slide, what we recommend is, make sure you have a pulse that says what you want. And some people start with refusing oral food. Some people stop eating. It's called voluntary stopping eating and drinking. That's VSAD. And there is I'll send it to Rebecca. There's a dementia addendum that I was meant to bring with me that you can add to it that says, if I have dementia and if there's some point where I don't know my family members, or at that point, I would not want to have antibiotics. Say I have pneumonia. This is what mine says. If I get pneumonia and I have dementia, then I want to be kept comfortable. Give me pain relief. Give me things to keep me comfortable and let me die a natural death at that point. There's a lot of over treating in this country with pneumonias and things like that. So there are proactive things you can do if you start to develop Alzheimer's or dementia. Okay. And again, that video recording of your health wishes really help. Okay. So again, just to look at the ladder of things, complete all the forms, and please, I hope that all of your treatment wishes would be honored. Let me get in there. These are the websites. I'll send them to Rebecca so you can go and fill these out again. And so Thank you for allowing me to spend some time with you today, and I'll be here to answer all of your questions.
Thank you so much, Karen, for your time. I wanted to open it up for those online.
Oh,
If they have
definitely.
any questions, feel free to put them into the chat. Or you can unmute yourself and let me know that way.
Oh, yeah, my God.
Karen? Oh, Karen?
Yeah.
Have you read the book?
We're waiting for those online. Okay, wonderful. Thank you again, Karen, for your time and for speaking about this important topic today.
No problem.